So, hello and welcome everyone to the Menopause Symposium, where we bring you new and up-to-date information from the world of menopause. My name is Bassel Wattar. I'm a menopause specialist from London, and I'm joined by my friend and colleague Vikram Talaulikar, who is a menopause specialist from University College London Hospital. Thank you all for all the interactions we saw on the channel and social media and LinkedIn. We've been receiving a lot of comments and requests for several articles, and we're very thrilled about it. And so, Vikram, our last episode on fezolinetant saw a lot of interactions, and we received quite a lot of requests to cover other sort of alternative to women with cancer. So today we are going to cover a very interesting article about the use of estrogen bazedoxifene combination, or Duavee, that could be a nice option for women with previous cancer. What is your experience with using this interesting drug combination, or HRT combination?
So thank you, Bassel, once again for picking up a interesting article. So Duavee was introduced in the UK. I remember having heard about it and was almost ready to try it or use it in some patients before COVID. But then after there were issues with either, I don't know, the manufacturing or the way it was licensed in the UK, that it got withdrawn from the market. It was thought to be reintroduced in the European market. I don't know whether it's available on the continent right now, but the main usage has all been in the US. So we haven't really had clinical experience with its use, but we've heard a lot about bazedoxifene on its own, standalone. That's definitely available in Europe, but also a little bit from the data that you're going to present. So let's see what the study says.
Indeed, indeed. And most of the literature that I could find was actually from the US, like you mentioned. And I think it's manufactured by Pfizer, if I'm not mistaken. We have a very interesting study where they looked into sort of insurance databases from the USA. They gathered a lot of information in terms of the safety and efficacy of Duavee. Perhaps you can tell our viewers on the concept behind Duavee and how it could be a nice substitute for of an HRT.
Okay, so traditional HRT combines an estrogen with a progestogen. Now that could be estradiol combined with various forms of progestogen, whether it's synthetic or whether it's natural progesterone. And there are so many different types of synthetic progestogen. The two things which are common with use of progestogen, and we know it's mainly used if there is a uterus in place and there is risk of endometrial hyperplasia or cancer with use of estrogen alone. That's when we add the progestogen, not for women who've had a hysterectomy generally. So if you use progestogen, one is a side effect profile. Progestogens usually will cause bloating, will cause the low mood, depression, premenstrual side effects, which can be quite severe for some women. And the major problem with progestogen use, as we know now, is the increased risk of breast cancer, which we attribute to the progestogen and not the estrogen. And so can we find a progestogen or a replacement compound that would first not cause some of the side effects, like the severe PMS, PMDD symptoms, two, not have the same bad impact on the breast. So it would be more or less like using estrogen only HRT if you could take away the influence of the progestogen. And that really is the key in terms of finding a replacement molecule while also protecting the endometrium lining, which is what it's supposed to be doing. And that's where the bazedoxifene was introduced to say, can we combine it with estrogen because it's a SERM, selective estrogen receptor modulator, has some antagonistic action on the breast, on the endometrium. So if it doesn't have the side effect profile of progestogen, if it doesn't stimulate lining of womb, doesn't stimulate breast tissue, you've got kind of all in all a great product there without the problems of progestogen. And that's how the combination of equine estrogen with bazedoxifene first came to use as an alternative to traditional estrogen progestogen HRT.
Indeed, I mean, the idea sounds very attractive, and that would be indeed I'm sure, a product in huge demand. But as always, we like to base our practice by evidence. So let's see what the evidence is saying. So this is a study, as we mentioned, from the USA, and they basically looked into databases of insurers claimers. And as you can see, the numbers are really big in terms of how many women were taking part in this. And I'm not familiar with these particular databases, but they're very sort of well established. And this practice is very common in USA because all the health system there is based on insurance provision. And basically, they looked into gathering data on all women who were of any age with medical or pharmacy coverage in the last 12 months that had either a Duavee or a standard estrogen progesterone HRT treatment. Now, they excluded those who had a hysterectomy, because obviously that will not be applicable to what we're talking about, those who had a previous cancer, and then those who used unopposed estrogen or other types of HRT. And they focused also, obviously, on the choice of the outcomes, which is often confirming the outcome in these databases sort of studies is often tricky, because they wanted to see was the incidence of hyperplasia, endometrial hyperplasia, incidence of endometrial cancer, cardiovascular events, or any type of other cancer. So they focused that these outcomes are not present at time of inclusion in the past 12 or 6 months. And so the exposure is obviously the either taken Duavee or taken any other estrogen progesterone HRT, and they were fairly flexible in terms of what sort of estrogen and progesterone combination to have. And as we discussed, they focus on several outcome of interest, so endometrial cancer, endometrial hyperplasia, VTE event, myocardial infarction, stroke, transient ischemic attacks, and also other types of cancer like ovarian cancer. Now, I know the statistics are quite interesting in this exercise, and they use something called propensity score matching. And for our viewers who are not familiar with this type, in very simple terms, is when the golden grail of every study is to do an RCT where you allocate the treatment at random. Therefore, you eliminate performance bias. So in here, when you want to do a propensity score matching, you trying to minimize that performance bias by estimating a propensity score for the likelihood of each participant to receiving treatment A versus treatment B. You generate a score using a logistic regression model, and then you compare and match the two groups between them while adjusting for that propensity score. So in a way, trying to almost create randomization within an observational data. It's becoming more and more of a sort of up-and-coming methodology that is really useful, because I think specifically since COVID, we became way much better in capturing these routine data uses with the advances in digital health. So we will see more and more of these studies, and they're very useful. Now, clearly, there are always important covariates to consider when you're looking for outcomes of menopause. And we both published on this very recently in our article in Climatrics, that there's a number of covariates we need to consider, confounders and moderators. And in this exercise, they're focused on age, sex, geographic region, time and from enrollment, and calendar from index date. Index date is the time that they were involved, or like they chose to start collecting data, and the presence of all other outcomes, health outcomes that they focused on. So before we move to the results, what do you think of such methodology in the world of menopause? I think it's quite interesting, because we often suffer from the low number of randomized trials in menopause, isn't it?
Yes, Bassel. So first of all, that seemed to be very complicated for me. Thank you for simplifying what it actually means in terms of the propensity score. Yes, you're right that very few RCTs, because it's time consuming. There aren't enough resources in menopause world. And for some outcomes like cancers, you would have to really look for long-term studies. And sometimes it's just practically very difficult to really do RCTs that long. So you might have to really try and get the best out of your observational data. So such studies would be very useful.
100%. So in this exercise, they looked on data from 92,000 plus women, which is
Oh
absolutely
gosh,
huge.
that's 90
Yes.
million. Gosh.
90 million. Yes, sorry. Yes, you're right. And then from there, they looked into 10,000 plus women that had Duavee versus 33,000 plus women that had all other types of oral, largely oral, aren't they? Yeah, I'm looking at the list. The majority of them are oral tablets,
Mhm.
except two that are patches. Combined estrogen progesterone HRTs. And the duration of follow-up was actually interesting in that the average follow-up for cancer was 22 months, which is relatively short to capture cancer after HRT. And then the average follow-up for endometrial hyperplasia and cardiovascular events were 10 to 11 months. And again, I think it's relatively short to capture cardiovascular events. That typically presents 5 years down the line from starting HRT. And they tried to adjust for endometrial hyperplasia because obviously, endometrial hyperplasia, while it is an outcome, is also a predisposing factor for endometrial cancer. So you have to be careful when you try to crunch the data that you don't miss the causality link between them, that one would lead to the other. So they try to adjust for that at baseline. And then so they captured 286 cases of breast cancer, and the breast cancer risk was actually less or reduced in the Duavee group compared to those with estrogen and progesterone, which makes a lot of sense because obviously, as we discussed, progesterone often, unfortunately, increases the risk of breast cancer. And when they, as we discussed, they adopted a 6 month lag time period between the index date starting the study and then capturing endometrial and breast cancer. And they found that in both cancers were actually smaller or like less common in the Duavee group. So when they looked into endometrial cancer cases, again, as we discussed, that it was lower in the Duavee group compared to those with the estrogen progesterone cancer as well, which the difference was actually quite substantial, is that it was 1.6 versus 5.2 versus 3.6. What do you think of these initial findings? It's quite interesting, isn't it?
Yes, so Basil, if I get that right, so the breast cancer was lower, but the
Mm,
endometrial hyperplasia and the endometrial cancer risk was higher, isn't it?
correct, exactly.
And so with the breast cancer risk, one would expect that because like tamoxifen, like raloxifene, you've got the bazedoxifene, all of them are consistently anti sort of breast stimulation. So you would expect that the breast cancer risk should be more like the estrogen only. So that's great. That's exactly, I think, what they wanted to show through the paper. But of course, it's a small follow-up that is important to keep in mind. With the endometrium, you could the overall slightly increase risk because the bazedoxifene does appear to be not as protective as a
Mm,
synthetic progestogen, which was the
exactly.
comparator group. But again, the figures are so small that the actual absolute risk is so tiny that it could still be a valuable option, say for women who can't tolerate the synthetic progestogen.
100%. And specifically, if you look at the cases of the endometrial hyperplasia, there are only 48 cases, even that we're looking at the relatively very big population numbers. So that tells you that, perhaps with accurate surveillance and monitoring, you can even lower these risks and eliminate that. Because obviously, what we don't know here, when I was looking through the paper, they did not impose a very robust sort of surveillance or monitoring with ultrasound or what investigation they
Yeah.
did with bleeding and so on. And this is continue to be an unknown in our case. And obviously, this is data from very several centers, so we would not know that the surveillance protocols were the same across them. So with such small numbers, as you said, it introduced the potential clinical value for Duavie in these women, specifically those with previous breast cancer, for example.
Mhm.
So, limitations. What do you think? You know, could reduce the certainty of the findings of this study?
I think you've kind of put them down well. The biggest one for me is the short-term follow-up, because really to comment on cancer, you really need 5 years or more of data. So 2 years would be a short time just on this particular medication. However, we have to go by what's available. But the other ones, for example, the sample size insufficient to compare this particular product with a
Yeah.
particular estrogen type or dose or regime or which combination really it compared with. They haven't specified subsets of, say, HRT preparations where you can make a direct comparison. That's all taken as one group of various estrogens, progestins. So again, that sort of comparison of different regimes wasn't there with Duavee.
Yeah, I completely agree. I think the short-term follow-up is a missed opportunity in terms of only 2 years. We'll probably see completely different profile if the data is available for 5 years or more. Specifically with observational data, you could argue this is somewhat more feasible than the randomized data. And something of great interest is, as you mentioned, is that when we looked at the table of the type of HRT that they were compared against, majority of them were synthetic progestin that we know are more associated with higher chance of cancers. And so while in today's practice we try to use more micronized progesterone and more sort of bioidentical progesterone, so it'll be very interesting to see how a comparison between Duavee and a more micronized progesterone option would yield in terms of different cancer risks. So I think as a fair conclusion, I think the judgment is still out there whether a option of like Duavee is sort of has its. I think it definitely has its place in terms of the repertoire of HRTs to offer. Probably not a first line option, but it's definitely somewhere down as a second or third line option for a very specific cohort of women. What do you think?
You're absolutely right. I mean, if there was one thing I could suggest to the company or the manufacturer is just to simply change the estrogen and then combine the bazedoxifene, because equine estrogen, conjugated estrogens are out now. They are horse-based products. They are very strong estrogens, traditionally were the bad guy in terms of the big trials, WHI and the others. So really, it's all about human estradiol, estriol now. So if they could combine a body identical estrogen with the bazedoxifene, that will be very attractive, especially for the women we talked about, those who are very worried about their breast cancer risk, those who are intolerant to progesterone with PMDD, PMS. If you could give them the combination and then make sure you kind of keep a surveillance on their endometrium, just because this data shows a slightly increased incidence of hyperplasia, as long as you're keeping a surveillance, this would be a typical niche group where this HRT would be really useful.
No, 100%. And I think because these particular patient subgroup, let's call it, they will typically be under more medical surveillance, and they will always have
Yeah,
follow-ups, but such option will significantly improve their quality of life. And that's another
correct.
limitation that we did not capture here, is that how did Duavee actually improve vasomotor symptoms and other
Yes,
symptoms that this was not reported in this study. And I think a more sort of comprehensive and randomized trial using better, more bioidentical HRT elements will be much more relevant to today's clinical practice, isn't it?
absolutely. It would be a dream to do a transdermal estradiol bazedoxifene versus transdermal estradiol progesterone versus transdermal estradiol progestogen. That would give us a fantastic answer. But of course, it's the stuff of dreams. We don't have money for it right now.
Well, maybe we can do this trial together sometime. Fantastic. Well, we're reaching the end of this very interesting study, and we'll definitely put the link for it in the case notes down below. Thank you very much, Vikram, for taking
Thank
us
you,
through
Bassel.
this paper today. And thank you for all the viewers. And please don't forget to sign up to our newsletter, subscribe to the channel, and we'll keep you updated with further episodes of the Menopause Symposium. Thank you very much.
Thank you.